on to start this session. Welcome, sir. Over to you.
Good morning, all of you.
Good morning, sir.
Uh, in the series of Journal Club and case presentations, today is another interesting topic, that is defining risk levels in locally advanced head and neck cancers, comparative analysis of concurrent post-op radiation plus chemotherapy. She's going to talk about the trials EORTC and RTOG trial, although the study is quite old, 2005, but quite important. You see, many times patients, I will say invariably the patients relations will ask you, ठीक तो हो जाएगा ना जी, गारंटी है ना जी. So then doctor says, it is a treatable condition, we cannot assure you cure. Then they say that what are the chances that he or she will be cured? So you need to assess the risk in these locally advanced cancers. And what are the chances that patient will have a recurrence, and whether you can reduce the chances of recurrent disease? Can you increase the overall survival? Can you increase the disease-free survival with some additional treatment, adjuvant treatment, that is post-op radiation, chemotherapy, immunotherapy, targeted therapy? So I'll request Dr. Manika to start defining risk levels in locally advanced head and neck cancers. Very important topic. I think every resident should know. That is the crux of your discussion with patients. And I'm sure you will be able to answer so many questions to the patient and relations. Over to you.
Thank you, sir. Good morning, everyone. So the today topic of my talk is my journal club defining risk levels in locally advanced head and neck cancers. So this is a comparative analysis of concurrent postoperative radiation plus chemotherapy trials of the EORTC, that's number 22931, and RTOG 9501. So this paper, it was published in 2005 in Head and Neck Journal. Now coming to the introduction. So for locally advanced head and neck cancers, squamous cell carcinoma, the primary approach, it was always a surgery, traditionally followed by the post-operative radiotherapy. Despite such relatively aggressive bimodality treatment, that is a surgery followed by the post-operative radiotherapy, this approach yielded loco-regional recurrence, distant metastatic rate, and the 5-year survival rate respectively of 30, 25, and 40% respectively. So, in 2004, level 1 evidence was established for the post-operative adjuvant treatment of patients with selective high-risk locally advanced head and neck cancers with the result of 2 trials, that is EORTC 22931 and RTOG 9501. So coming to the another important thing, adjuvant chemotherapy, enhanced radiation therapy was shown to be more efficacious than post-operative radiotherapy for these tumors in terms of locoregional control and disease-free survival and overall survival. Main aim and objective of the study was addition of the concomitant cisplatin to post-operative radiotherapy, which improves the outcome in patients with one or both of the risk factors. The risk factors which were included: extracapsular extension, microscopically involved resected margins, and the patients who are medically fit to receive chemotherapy. Coming to the methodology, addition of concomitant relatively high doses of cisplatin, respectively on days 1, 22, and 43 to radiotherapy And there are the two arms which are included in the methodology. The one arm is the cisplatin with radiotherapy, and the another arm is the radiotherapy alone. So radiotherapy in both arms consisted of the 60 grays with or without 6 grays boost in RTOG trial, and the another one is a 66 grays trial in the EORTC trial, which was delivered through the conventional fractionation regimen of 5 once daily sessions per week, that is 1.8 to 2 grays per session, and 5 days per week. So cisplatin was given in a dose of 100 milligram per body square meter on days 1, 22 and 43. Coming to the respective trials, as in this paper, both the trials they were compared, and the significant results were obtained on the basis of the primary endpoint and the secondary endpoint. So in our EORTC trial, the 334 patients were taken, and the primary endpoint was progression-free survival. Compared to the RTOG trial, in which the 459 patients were enrolled, and the primary endpoint was loco-regional disease control. And high-risk features in EORTC trial included, these were the presence of tumor at the surgical section margins, that is at the 5 mm or less, extracapsular extension of nodal disease, clinical involvement of lymph nodes at level 4 or 5 from carcinomas arising in oral cavity or oropharynx. Then the another one is a perineural disease and the vascular embolism. Coming to the RTOG trial, in this the primary endpoint was loco-regional disease control, and the high risk factors were the presence of tumor at the surgical section margins, extracapsular extension involvement of 2 or more lymph nodes, and the median follow-up for the EORTC trial was 60 months, and respectively in RTOG trial it was 46 months. Coming to the eligibility criteria in the EORTC and RTOG trial that I discussed. So in EORTC trial, it was stage 3 and stage 4 cancer of oropharynx or oral cavity, perineural disease, vascular embolism, and included with the positive margins, positively resected margins with extracapsular extension. And in RTOG trial, it was the positive nodes 2 or more along with the margins and the extracapsular extension. Coming to the demographic variability of the patients. So in EORTC trial, the demographic variables which were taken, these were the tumor staging, nodal staging, primary tumor site, resection margin status, histologically differentiation, extracapsular spread, and perineural involvement. While in the RTOG trial, the main features which were highlighted were the positive margins and the 2 or plus positive nodes or extracapsular extension. And the another one were the Kanofsky performance score and the site of tumor. Coming to the statistical analysis. So comparative analysis were done from both of the trials. The assessment of 3 endpoints were there from both of the trials, which were pooled together, and the primary endpoint from the EORTC trial, it was a loco-regional control, and in the RTOG trial, it was a disease-free survival or the progression-free survival, and the secondary endpoint was the overall survival. So all the endpoints, they were estimated by Kaplan-Meier method, and the differences were assessed by log rank or Cox model. Hazard ratio of these endpoints were seen during the statistical analysis, and the hazard risk ratio of less than one will favor the chemoradiation. So coming to the statistical analysis, this is the forest plot curve in term for the disease-free survival. So the in figure A, we can see the impact of adjuvant chemoradiation on disease-free survival. That is the primary endpoint in the RTOG trial. It was chemoradiation. In the EORTC trial, the risk reduction was 25% with the chemoradiation, and in RTOG trial, the risk reduction is 22% with the chemoradiation arm. And the pooled analysis, it showed the 23% of the risk radiation and the chemoradiation arm. Then the same comparative analysis of hazard ratio was done for the subsets of the patient either eligible for both of the studies in EORTC and RTOG, and eligible for either only of the one study. And comparatively, in all, as compared to the treatment hazard ratio for all patients with respect to the subsets, the chemoradiation was having a better survival rate in terms of disease-free survival when the in the subgroup analysis for both of the studies, as we see in this forest plot. So this is the forest. So this is the forest plot. This is the line of null effect, and this horizontal line, it refers to the number of studies, like three, like the two studies are done, so corresponds to the horizontal line, and the square corresponds to the sample size. So the horizontal line, which was present to the left side of the vertical line, this shows the significant and the better results. That showed the that means the chemoradiation had a better survival rate as compared to the radiotherapy alone in all the patients. Then coming to the loco-regional con then coming to the loco-regional control, which was the primary endpoint, in the EORTC trial. So again, this was a forest plot plotted for the comparison of the chemoradiation versus radiotherapy. So with the chemoradiation in EORTC trial, the risk reduction was by 45% as compared to the RTOG trial, in which the risk radiation with chemoradiation, it was 39%, and with the pooled analysis, it was 42% with the chemoradiation as compared to the radiotherapy. Again, coming to the subset analysis, in the respective trial in the EORTC, the hazard, the risk ratio was 55%, and in RTOG trial, it was 49%. So again, the comparative analysis of hazard ratio was done for both of the studies versus the patient eligibility for only one study. Coming to the impact of adjuvant chemoradiation on overall survival in both of the trials as compared to the patients who are eligible for the both of the trial versus one trial only. So chemoradiation, sorry, chemoradiation gave the better results in terms of the risk ratio, which was risk reduction, which was 30% in EORTC trial with the chemoradiation arm, and in RTOG trial it was 16% with chemoradiation. And again, the pooled analysis, the 28% risk reduction was there in chemoradiation as compared to the radiotherapy arm. Coming to the overall survival in terms of subset, so the patients who were eligible for both of the studies, the hazard risk ratio is the 66% in EORTC trial, and the RTOG trial it was 73%. And again, the horizontal line, it was present left to the mid vertical line. There's a line of null, so it showed a overall survival was better for both of the for the EORTC trial as compared to the RTOG trial in the chemoradiation arm as compared to the radiotherapy. While the patients who were eligible for only one study, both in the EORTC and the RTOG trial, the overall survival was the comparable. And then coming to the impact of risk factors on overall survival. So the impact of risk factors, it was major. There's a risk factors with positive margins and with extra capsular extension, which was included in this paper. It was having a significant effect as compared to the overall survival when we had a patients without positive margins and ECA. This is the Kaplan-Meier method, in which on the x-axis there is a time interval, and on the y-axis there was a survival method, and the survival was in a comparison was compared with the time interval. So coming to the summary of trials, so in EORTC trial 22931, in which the 334 patients were taken, the endpoints, the primary endpoint of EORTC trial, as I discussed earlier, it was a loco-regional primary endpoint was the loco-regional rate. So it was 18% in chemoradiation arm versus the 31% in radiation arm. Then coming to the overall survival rate, it was 53% with chemoradiation arm as compared to the radiation arm alone after 5 years. As compared to the RTOG trial, which was 56% in chemoradiation arm as compared with respect to 47% in radiation arm. So these are the incidence of late adverse effects in the EORTC trial. The late adverse effects, they were xerostomia, dysphagia, fibrosis, shoulder syndrome, lymphatic drainage, impairment, laryngeal complications. So coming to the RTOG trial with the in this table we can see with the combined therapy, the risk is, the complications are more as compared to the radiotherapy given alone. So coming to the discussion, two randomized phase 3 trials conducted independently on both sides of Atlantic by the EORTC and the RTOG. Role of adjuvant chemoradiation in the management of locally advanced head and neck cancers was clearly demonstrated. Concomitant delivery of high doses of cisplatin and radiation over post-operative radiotherapy in terms of locoregional control and disease-free survival was demonstrated. Secondary endpoint was overall survival in both of the trials, and it was found to be significantly improved by delivery of concurrent chemoradiation in EORTC trial as compared to RTOG trial. And previous RTOG study, which tested the value of sequential postoperative chemotherapy and radiation therapy, suggested three risk groupings. The lowest risk when fewer than 2 nodes were histologically involved, no extracapsular extension was present, and surgical margins were not histologically uninvolved. Mid risk when at least 2 nodes were involved or extracapsular extension was present, and surgical margins were not histologically uninvolved. Highest risk was when the surgical margins were histologically positive. Coming to the criteria given by the University of Texas, the risk factors confirming the worst prognosis, the highest risk was in which the 2 or more factors were present, that is the presence of microscopically involved margins of resection and the presence of extracapsular extension along with the 2 or more lymph nodes invaded by tumor. And the low risk was in which none of these factors were present, and the intermediate risk is in which only one of the preceding factors were present other than extracapsular extension. Coming to the criteria given by University of Pennsylvania, the intermediate risk, it was associated with the finding of lymph nodes of at least 3 centimeter in diameter, perineural or perivascular disease, invasion of cartilage, bone, or soft tissue, and the presence of 2 or more involved nodes, extracapsular extension, and microscopically involved margins of resection was shown to significantly increase the failure risk. That is the highest risk group. So, in attempt to define more precisely the risk levels in primarily cases of head and neck cancer and identify the factors that might explain the difference in effect of CRT was observed in EORT in both of the trials, and collaborative comparative analysis of selection criteria and treatment related parameters in both studies was done. Drawback: Chemotherapy doses were found to be similar in both of the studies. With respect to radiotherapy, a very small fraction, that is the 13% of patients in RTOG trial, compared with the 91% of patients in EORTC study, received a total dose of 66 grays. And in contrast, comparative analysis of nodal distribution indicates a striking difference in N2 nodal stage across the two trials. That is, the 94% were in the RTOG trial and 57% with the nodal distribution of N2, N3. They were included in the EORTC trial, EORTC study that had a significant effect on the survival of the patient and thus the primary endpoint. Thus on the primary endpoint. So coming to the conclusion, in locally advanced head and neck cancer, microscopically involved section margins and EC extracapsular extension from neck nodes are the most significant prognostic factors for poor outcome as measured either by locoregional recurrence or the survival endpoints, which were different in both of the studies. The addition of concomitant cisplatin to post-operative radiotherapy seems to improve the outcomes of patient with one or combination of these two risk factors, whether measured by locoregional control, disease-free or progression-free survival, or overall survival. Although detectable, the contribution of adjuvant chemoradiation in the group of patients who have stage 3, stage 4 disease, perineural infiltration, vascular embolisms, and level 4 and 5 lymph nodes secondary to tumors of oral cavity or oropharynx seems to be less important in this combined analysis. So the major factors which were having the highest weighted and having are among the significant prognostic factor were the microscopically involved section margins with extracapsular extension from neck nodes. Other than these factors. So, this is the paper from the Borneo. It was the post-operative irradiation with or without concomitant chemotherapy for locally advanced head and neck cancer, published in 2005. In methodology, again, I had discussed already, 334 patients were taken in EORTC trial, and they were randomly and the subjects were randomly divided into the two groups, the two arms. The one arm was the radiotherapy alone, in which the 66 grays of the radiation was given over a period of 6.5 weeks. And the another 167 subjects, they were exposed to having the radiation with a combination of chemotherapy. There is 100 milligram of dose was given on day 121, 22, and 43 of radiotherapy regimen. So the results after a median follow-up of 60 months, the rate of progression-free survival, it was higher in combined therapy group, that is the radiation with the chemotherapy, with a 5-year survival rate of 47% as compared to 36% in radiotherapy alone. And the overall survival was also significantly higher in the combined therapy group than in the radiotherapy group, with a 5-year survival rate of 53 and 40%. Then coming to the local or the regional relapses, which was significantly lower in the combined therapy group because of the usage of chemo as well as the radiation. And the estimated 5-year cumulative incidence of locoregional relapses was 31% after radiotherapy and 18% after combined therapy. Severe grade 3 or higher adverse effects were more frequent after combined therapy because of the concurrent chemoradiation than as compared to radiotherapy. Then coming to the another the trial RTOG 9501, postoperative concurrent radiotherapy and chemotherapy for high-risk squamous cell carcinoma of head and neck by Cooper. Methodology in this 459 patients were enrolled and 231 patients were randomly assigned to receive radiotherapy alone, either 60 to 66 grays over a period of 6 or 6.5 weeks, and 228 patients in another arm received a similar treatment of radiation with concurrent cisplatin. Coming to results of this trial, the rate of local and the regional control was significantly higher in the combined therapy group than in the group given radiotherapy alone. The estimated 2-year rate of local and the regional control, it was 82% in combined therapy group as compared to 72% in radiotherapy group alone. Disease-free survival, which was significantly longer in the combined therapy group than in the radiotherapy, but the overall survival was not very much differ in um, both of the groups. Thank you.
Thank you, Dr. Manika. Well done. Dr. Deepak,
Anji, good morning.
comments.
So Monica, I have some questions for you.
Yes, sir.
In 4 lines, can you summarize your interpretation of using chemoradiation as adjuvant therapy after surgery? What is your take-home message?
So the take-home message from this study, it was this with adjuvant concurrent chemoradiation, which we are using after assessing the risk factors, it was having a significant effect on the overall on the primary endpoints that were disease-free survival and the progression-free survival. Um, and on the overall survival also. If we use the concurrent chemoradiation, we had a better survival rate as compared to the radiation alone.
Local recurrences,
Sir, sorry.
impact on local recurrence.
Yes, sir. So the impact on loco-regional recurrences that were more in the with the radiation, yeah, that were more with the radiation along as compared to the concurrent chemoradiation.
And at what cost does this come? At this extra benefit comes at what cost?
Sir, at the cost of the uh, side effects of the radiation and the chemo which the subjects were having in the respective trials.
So were they the same? That's the question.
No, the effects were not the same. The effects were more in the concurrent chemoradiation trial as compared in the CT-RT group as compared to the RT group.
Right. I think when the trials came out, I mean, there was a lot of discussion around these because for the first time we had level 1 evidence in deciding can we um, up escalate adjuvant therapy. Uh, and the consensus was that yes, you get a modest benefit primarily driven by loco-regional control, but it does come at the cost of significantly increased toxicity, and that must be kept in mind.
Yes, sir.
Also, one will have, so therefore, while practically when we see these high risk histology factors, which is positive margins or ENE in a lymph node,
Yes, sir.
the knee-jerk reaction is to add chemoradiation. But there are certain patients, possibly practically, where it may not be the best to go through because they will have increased toxicity. One has to judge the patient's ability to take this therapy. And also in general, if you see most trials which have done chemotherapy concomitant with radiation, the benefit seems to peters off in patients who are more than 70 years of age. So these are factors one has to keep in mind when one is prescribing adjuvant therapy. It shouldn't be a knee-jerk to look at the histopath report and decide what needs to be done. You need to keep in mind the patient's age and the patient's ability to take the increased toxicity, which we know happens when you give chemoradiation as compared to radiation. But by and large, the oncological effect is now without question. That is crystal clear.
Dr. Manika, there are questions in chat box whether the combined therapy should be given to all these three risk groups in locally advanced carcinoma in same dose. So
So according to the risk factors, we can go for the concurrent chemoradiation. Like I discussed the different risk levels: low, intermediate, and the highest risk. According to me, what I understand, in the highest risk group, we can have the concurrent chemoradiation as compared to the lowest risk, lowest risk factor, in which the factors were less, and the significance of the concurrent chemoradiation was not much significant as compared to the highest risk.
he is
Yeah.
talking of the dose of radiation in different risk levels.
Yes, sir. Dose of the radiation, it will be same in all of the uh, risk factors, whether it is low, high, intermediate, and the highest.
Is 66 grade?
Yes, sir. 66, it varied from 60 to 6, it was in the range from 60 to 66 grays.
Dr. Serene,
Yeah.
I
So
think the dose will vary. The high risk areas may need a boost. You may go on to 66, but by and large, it remains the 60.
60 grays.
I, I completely agree with you. I think the radiotherapist, when planning, may choose to boost some areas to a higher dose. I mean, for example, if you have extranodal extension and there is incomplete removal of disease of the carotid or any other areas, or you have positive margins in one area, the radiation oncologist may choose to boost certain areas. But by and large, based on the risk groups, we don't sort of stratify. For as far as the risk groups are concerned, the dose is prescribed is the same, but certain patients may need a boost.
And the next, first question was uh, from Dr. Lakshmi. For everyone eligible for only one study, please explain it once in the graphs.
Sorry, I'm not, matlab,
Just
uh,
read it. Even there's no clarity in the question.
sir, I'm not having that chat box thing. I'm unable to open the chat box
Dr. N.
from
Rajya
my side.
Lakshmi, to everyone eligible for probably eligibility for only one study. Please explain it once in the graphs. I think we can go on to the next question.
And there aren't any questions.
Toxicities, I think we have discussed. Can you explain the toxicities again if radiation and chemo are combined?
Uh, yes, sir. So in the EORTC trial, the cumulative incidence of severe grade 3 or grade 4 adverse effects were significantly greater in the combined therapy group as compared to the radiotherapy group. And it was noted in the EORTC trial, 41% in the combined therapy group as compared to the radiation group, which was 21%. And respectively, in the RTOG trial, after addition of chemotherapy to radiotherapy, will going to increase the incidence of severe adverse effects, and the percentage was 34% who received the radiotherapy alone, and as compared to the 77% who received the concurrent combined therapy.
Can you enumerate the early side effects and late side effects? I
Yeah.
think this is there in your chart, but I think for the benefit of candidates, you can enumerate.
Yes, sir, sure. So the acute adverse effects from the combined therapy, they were having a effect on the, these were the anemia, mucositis, diarrhea, on the respiratory effect, on the respiratory tract, and hematological evidences also. But in the but the late side effects will be on the salivary gland, like xerostomia, And the neurological involvement like encephalopathy and the hematuria by the involvement of the renal system, and the of course the skin involvement is there in the late stages that will lead to the tumors.
That will lead to the tumors.
I mean matlab, the uh, sir, I'm in the late side effects. These were the mucosal necrosis, skin, and the connective tissue fibrosis. These were the possible adverse effects.
Classically, the side effects of plain radiation and side effects of cisplatin. Okay.
Yes,
You
sir.
should know what are the other options if a patient has got some nephrotoxicity already, say compromised renal function or
Yes, sir.
some neuro problems. What are the other options you have to be added to radiation? And what is the mechanism of action of cisplatin when it is used along with the radiation?
Yes, sir.
That you should know. This might come for
Yes, sir.
discussion in practical exam.
Yes, sir. So cisplatin is among the alkylating agent, which is going to act on the DNA and prevents the uncoiling of the that prevents the uncoiling of DNA. That is a very important step in the replication and for the replication process. So cisplatin will going to prevent this step and thus having the action on the tumor site.
Okay. I think this you have answered. Impact of adding chemotherapy on overall survival, you have already answered. Risk groups you have already given. And then role of biomap, somebody has asked.
Sorry, sir. Roll off.
Biomap.
Sorry, I don't know.
Okay. Whenever a patient already has compromised renal function, elderly patient has got high risk of complications with cisplatin, biomab is another option.
Okay, sir.
Okay.
Yes, sir.
Any
So
other question?
I have a question, Manika, since we have time. A much more simpler question. There was a lot of talk of hazard ratios in your presentation.
Yes, sir.
Can you explain to us in simple words what do you understand when you make the statement with chemoradiation, the hazard ratio was zero point 0.8 for local recurrence? What do you understand by 0.8?
So, hazard risk ratio, it basically quantify the impact of treatment by providing the risk of treatment failure for patients in one treatment group as compared to the another. So, like in this figure A, the hazard risk ratio, it was the hazard risk ratio, first of all, it was always in the figures, like it was 0.54 in EORTC trial. So the 54 percent of the subjects, they were at the they were having the relative risk of having the treatment failure as compared to the radiotherapy alone, and 45% is the the risk, it has been reduced by 45% in the chemoradiation trial in the chemoradiation subject as compared to the radiotherapy.
Okay, excellent. So are there any other questions we can take?
I think chat box is empty. She's answered all. So I think with this, you will be able to answer few of the important questions at least about the adjuvant treatment. Majority of the patients and relations will ask you, sir or madam, what is the risk that patient will get recurrence, or what is the survival, and whether radiation is required at all or not, whether we need to add chemotherapy or not. These are some of the pertinent questions which you have answered. Well done. And
course.
we can call it a day. Dr. Manika,
Yes, sir.
good day.
Thank you, sir.
Bye-bye, Dr. Deepak Sareen.
Bye-bye. Thank you
Bye-bye.
very much.
Bye. Navneet ji, can we call it a day?
Yes, sir. Thank you very much, trainees and
Thank
faculty
you.
members, for joining the
Short
session.
presentation, but sweet one.
Thank you.
Thank you.